Bismillahirrahmanirrahim. This is the sixth video in the series of acute and chronic inflammatory dermatosis, and this video will cover the seborrheic dermatitis. These are the references for this video. Another entity included in the chronic inflammatory dermatosis is seborrheic dermatitis. Its prevalence is 5% in US, and it is distributed in the region with high density of sebaceous glands such as scalp, forehead, especially the glabellar region, external auditory canal, retroauricular area, nasolabial fold, and pre-sternal area. Despite its association with the uh, sebaceous gland, it is not a disease of sebaceous gland itself. It is associated with inflammation of the epidermis. The exact pathogenesis of seborrheic dermatitis is unknown. However, the increased sebum production as a result of increased androgen, is related with the seborrheic dermatitis, and it is one of the suggested pathogenesis. This is supported by patients of Parkinson's disease, where uh, this Parkinsonism is due to dopamine deficiency, and it results in the increased sebum production, and as a result there are lesions of seborrheic dermatitis. However, when the patient is treated with levodopa, these lesions disappear. So it is strongly related with the increased sebum production. But acne that has also got increased sebum production is not associated with seborrheic dermatitis. There is not enough sebum produced to cause the lesion. There are suggestions that fungus such as Malassezia is also associated with seborrheic dermatitis. Colonization of the skin by these fungi, they lead to the increased sebum production and seborrheic dermatitis. In HIV infections, especially the HIV infection where the CD4 count is very low, it results in severe form of seborrheic dermatitis. But after the introduction of antiviral therapy for the AIDS, the incidence of these lesions has been decreased. The lesions of the seborrheic dermatitis are macules and papules that have got an erythematous yellow or greasy base, and there is especially association of extensive scaling and crusting. This picture is showing the seborrheic dermatitis of the cheek, and also there is some seborrheic blepharitis also. Then the seborrheic dermatitis is also associated with the fissure formations, and these fissures are especially located behind the ears. The seborrheic dermatitis of the scalp is associated with extensive uh, presence of dandruff, and this picture is showing the lesion of the seborrheic dermatitis that is extensive and extensively involving the cheek, and these type of the lesions that are more severe and extensive are seen in AIDS patients, especially the patient with low CD4 count. The histopathological features of the seborrheic keratitis share the features of spongiotic dermatitis and psoriasis. The earlier lesions exhibiting the features of spongiotic dermatitis, while as the disease progresses, the features of psoriasis or acanthotic lesions are more prominent. There is presence of parakeratosis and neutrophil with serum at the ostia of the hair follicle that is termed as follicular lipping. The infiltrate that is present in the superficial perivascular area, and it consists of mixture of lymphocytes and neutrophil. So the disease can be acute, subacute, or chronic spongiotic dermatitis. In the acute lesions, there is focal mild spongiosis with the overlying scale crust that contains few neutrophils. The crust is often centered on a follicle. Papillary dermis is mildly edematous. Blood vessels in the superficial vascular plexus are dilated and there is mild superficial perivascular infiltrate of lymphocyte, histiocyte, and occasionally neutrophils. Some exocytosis of inflammatory cells is there, but not as prominent as in the nummular dermatitis. Then there are some subacute lesions. In subacute lesion, there is no psoriasiform hyperplasia initially. There is slight, mild spongiosis, and the other changes that we have just described earlier. Yeast-like organism can also be found in subacute type of the disease. The chronic lesions of seborrheic dermatitis are associated with more pronounced psoriasiform hyperplasia, and there is minimal spongiosis. This photomicrograph is showing the features of a biopsy specimen from the lesion of a seborrheic dermatitis. There is upper dermal lymphocytic infiltrate and presence of epidermal spongiosis, parakeratosis, and hyperkeratosis